Hello, I'm very excited to be here. This is my third year speaking for the DefCon Group's virtual village, and I've enjoyed my experience speaking here every single time I get the honor. Today I'm going to be talking about gender-inclusive features across the health information system. Can everybody hear my mic okay?
Affirmative.
Yes, indeedy.
Yep.
Perfect. So who am I? As you've just heard, I'm Squiddy. I'm the founder of DC574, which integrated with Michiana InfoSec. I am a graduate student at IU, finishing up my master's in health informatics. My education is tailored around health information security and medical device security. Next year in 2024, I'm going to be starting my PhD in security informatics. I'm a medical laboratory scientist. I completed my clinical rotations in South Bend during the pandemic. I'm a laboratory informaticist and more recently a desktop engineer because I wanted to try my hand at taking on a more traditional IT role. If you speak to anyone who knows me, you'll learn that I am a loudmouth, opinionated lesbian hacker. I'm absolutely not sorry for that. So why am I giving this talk, right? Because I'm gay, I'm trans, and I'm invested. And also because until quite recently, I was a healthcare worker. I think that queer healthcare, especially trans healthcare, needs to be talked about from a gay and trans perspective. And if we don't talk about it, then people with less experience living in our shoes will, and their voices will drown ours out. I think that our voices need to be the most prominent in the discussion revolving our healthcare as it applies to us, to make sure we stay alive. We deserve to both speak and have our voices heard, and that's especially important to me as a gay person of color. So it's important to me that you know that there are people just like you in healthcare fighting for inclusive care. You might notice my tone is a little bit more serious or sullen during this talk, and that's because this is an issue that's very near to my heart. I'll try to keep things a bit more upbeat, but no promises. And if you notice a pause, it's because I've got tea right beside me, so I might sneak a sip here and there. For my LGBT elders and siblings from around the world, I use the term queer in my presentation. Many young people in the LGBT community here in the West have chosen to reclaim this term. I mean no disrespect by using this term, and you may choose to substitute it with the term of your choosing. Likewise, I use the term cis for people who do not identify as transgender, but if you feel like that term's not for you, feel free to replace it. That being said, for our straight and cis allies, please be aware that the term queer has until recently been used as a slur against LGBT people and is still used as a slur in some parts of the globe. If someone has not chosen to identify themselves as queer, please do not refer to them as such. I ask that you use their preferred terms and please be respectful. And if you're here as an ally, thank you for coming. I hope that you gain some knowledge on the struggles that LGBTQ patients face. So today we're going to talk about a couple of things. We're going to talk about gender-inclusive features in healthcare. We are going to talk a little bit about where your PHI goes when you go to the hospital. We're going to talk about how hindering the flow of healthcare data, either intentionally or unintentionally, can be a patient safety risk, and how trans patients can be more impacted by this risk. Lastly, we're going to talk about how gender-inclusive features in healthcare can not only protect trans patients, but improve care for all patients. So what do I mean by gender-inclusive features in the healthcare system? Gender-inclusive features, at the very least, include support for gender identity in a patient record, along with support for preferred name and preferred pronouns. These features being included for patients facilitates gender-inclusive care by allowing patients to be treated as their authentic selves. I want to stress that gender-inclusive features are not optional in facilitating inclusive care. They're a requirement of inclusive care. You can't claim to support or offer inclusive care if your gender diverse and sexual minority patients don't feel safe or like they're receiving care from providers who treat them with respect. Healthcare providers are in a position of power over their patients, and they need to be mindful of this dynamic when trans patients are seeking treatment and asking for help. These patients deserve to be treated with respect. Incorporating gender-inclusive features benefits everyone, from trans patients to gender non-conforming cis patients, patients who are visibly queer, like our butch and masked lesbians. We should be giving all patients the option to include information that they feel is integral to their identity and who they are as a person. One simple example that I can think of right away is preferred name. I know a lot of people who don't identify as queer who would feel safer going by a nickname with their providers where possible, rather than having their legal name shouted across a waiting room. As transgender patients, we are at an increased risk. We have an elevated risk of overall mortality compared to cisgender patients, unrelated to gender-inclusive treatments like HRT or gender-affirming surgeries. We may avoid receiving health care if we feel like our experiences with a provider is invalidating, and that contributes to that mortality rate. Those of us who seek to fully transition from our sex assigned at birth and seek to have that transition reflected in our patient record can experience a delay in our care related to a demographic mismatch. I want to go into more detail regarding demographic mismatches, but first you're going to need to understand where your data goes when you go to see the doctor, or you go to get your labs drawn, or you go for a procedure. Your data doesn't just touch one system. You don't just get registered and that information goes to your chart and then everything just works within that EHR system. Your information is actually going through a web of health information systems, and an EHR is only one of them. I also want to point out here that transgender patients who otherwise already fall into a marginalized category are even more at risk. For example, a trans person who is assigned female at birth, or who is autistic, or a Black trans woman, or a trans person who's living in poverty already experience an increased risk to their patient safety, along with patients who are not trans but who are otherwise marginalized. Healthcare providers need to pay attention to the experiences of these patients in order to truly improve healthcare for everyone. Patient safety risks have the potential to impact some patients more than others. So the big question, where does my data go, right? And why does it matter? When I go to the hospital, where's my information flowing in that web? So to return to that web of health information systems that I mentioned, a health information system is a system that manages healthcare data. Examples of health information systems include electronic health record systems like Epic Hyperspace or Hyperdrive, laboratory information systems such as Beaker or SoftLab, and radiology information systems, just to name a few. Healthcare data includes your protected health information, or PHI, which can be written, spoken, or electronically recorded in some form. This information is protected by HIPAA, and there are actually 18 different identifiers for protected health information. But healthcare data is made up of more than just that. It's also comprised of your lab results, x-rays and imaging, and procedures. So I say across the HIS, but it's really across various health information systems. And there are different standards for transmitting this data that you've probably already heard of, such as HL7 FHIR and DICOM. For those of you who came to my talk last year, I spoke a little bit more in depth about the medical laboratory and the laboratory information system, but in reality, that's only one part of a much larger healthcare system. There are various departments like radiology that also exist and manage your health information. So think of each bit of your information, from your sex to your date of birth, your legal name, your test results, your patient history, all flowing through multiple systems. And each time it goes from one system to the next, there exists a possibility that your data is not going to flow cleanly. This can be for a number of reasons, right? So one of which is that hospitals don't always stick with one software created by one company like Epic. They might use Epic's EHR system, but they might use SoftLab or Cerner for their laboratory information system. They might use MobiLab for their phlebotomists. So while Epic's EHR might support gender identity, the laboratory software that the patient data is flowing to and from might not. This might not stop data in its tracks, but the result values that the lab sees may be different for transgender patients who, for example, are undergoing HRT, and it might flag a value as critical, and there might not be context that, oh, this patient's trans, and their expected ranges are going to be a little different. So that's just an example of how data might not flow from one system to the next perfectly cleanly or all in one piece. Some areas where your data is viewed by healthcare providers, they might not have the same information that your other providers might have. They might be working with a limited data set. For example, if your primary care doctor refers you to a specialist who's outside of your system, your data will be fragmented. According to a survey by Black Book Market Research in, I think it was 2018, 18% of patient EHRs are duplicates. As a result, already roughly about 1 in 5 patients have incomplete health records. So if there's 10 or more people listening to this talk right now, at least 2 of you have incomplete health records. So sometimes what can happen is that certain aspects of your data, such as your sex or date of birth or name, not flowing cleanly can cause what I'm going to refer to as a hiccup or a roadblock, where your data can't flow from one system to the next because an aspect of your data doesn't quite match, and this is known as a patient demographic mismatch. Demographic mismatches can occur for a multitude of different reasons, and they delay patient care, not just for the patient receiving care, but for other patients also receiving care when resources are limited and hospitals are short-staffed, which we know right now that they are. A mismatch can lead to information like test results being merged to the wrong patient chart, erroneous diagnostic lab results, duplicate medical records, and in more severe cases can result in incompatible blood transfusions and errors in medication administration. As trans healthcare gradually becomes more accessible, there's been an increase in patients seeking to transition and update their sex marker. I anticipate that the frequency of demographic mismatches will increase if we don't start putting inclusive care features into place now. In my opinion, this is something that our healthcare providers should have already been pushing more for and more frequently. A demographic mismatch is part of a larger problem referred to as patient misidentification. Some of the most recent data we have on patient misidentification errors is from a 2016 deep dive by the ECRI Institute, which found that while most mix-ups were caught early, 9% of identification errors resulted in death or harm to the patient. Ideally, we want this number to be 0%. And according to Imprivata, preventable medical errors are the third leading cause of death in the United States, causing an estimated 440,000 deaths per year. That's not an ideal solution for anyone. So a mismatch can happen to any patient. It can, for example, result from a patient being registered incorrectly in the system upon admission. This would be referred to as a patient misregistration, but it's more likely to happen to patients who frequently update certain aspects of their information. For example, trans patients who undergo a sex change and then seek to update their sex in their electronic health record, a field meant to contain a patient's sex assigned at birth. A patient who has recently requested that their sex be updated in their patient record may encounter an issue if their sex doesn't also match in another system like the LIS. For example, if a patient has their sex changed in their EHR between the time a laboratory test is ordered and run and the time a test is resulted, a mismatch error can occur, preventing the patient's test result from being able to flow back out of the LIS to the EHR. Systems do consider other patient variables like date of birth or name when linking patient data, but typically a mismatch in a patient's sex will be a showstopper as it can result in life-threatening circumstances. If a mismatch occurs in the laboratory between the test being run and the information being released out to the patient chart, the lab will call a team of specialists who work with the laboratory information system. I was one of these specialists, and I would occasionally get a call where this had occurred. It's not always something that is life-threatening, but it can take some time to correct sometimes, and test results can be delayed in that time. So if a mismatch occurs late at night, say 3 a.m., the lab may already be understaffed when this error is encountered. And I'm going to go into a few patient examples on the next slide. So why would trans patients seek to alter or not alter their sex marker? So some trans patients who are assigned female at birth may transition while keeping our sex listed as female in our chart so that we can receive notifications and recommendations for preventative screening and continue to receive insurance coverage for said screenings, such as mammograms and pap smears. A trans woman with diabetes who is on a specific dosage of her medication may choose to keep her sex listed as male to ensure that the correct dose is prescribed. However, a lot of trans patients who opt to change our sex marker because, a lot of us will opt to change our sex marker because more often than not, if we don't, we run the risk of encountering healthcare providers who really just don't respect our identity, who don't use our preferred pronouns, and who could discriminate against us simply because we're trans. And that's a horrible thing to have to talk about, but it's a reality for a lot of us. Even when there is support for gender identity field in an EHR, doctors might want to limit that what sort of information can be in those fields, for better or for worse. For example, in my case, after coming out as trans mass to my provider, They had to include my identity in the EHR system as trans male or have my gender state that I'm a trans man, because the term trans mask, which is not the same as trans man, may not help me if I decide to start HRT. That is to say, my provider listing me as a trans man makes it more likely that my insurance will cover the cost of hormone replacement therapy. And even if I decide to undergo a full transition, I might keep my sex marker as female to receive coverage, again, for preventative care. And because being a medical scientist, I know that there are different risks for individuals who are assigned female at birth, and we require different preventative care, and we'll have different result ranges for things such as kidney function, even after a full transition. So in order to receive that care and have my provider be aware that my test results are going to fall into a specific range, it's easier and safer at this point for me to keep my sex listed as female, but have my gender registered as trans. And this can be problematic because let's say that I present to the ER one night at 2 a.m. in critical condition. I'm going in and out of consciousness. ER staff are only able to obtain partial information about me, but I decided to transition and present as fully male. And they register me as male, right? But I'm listed as female in my electronic health record still. That can cause a demographic mismatch, which can delay testing and care when I'm in a critical state. And some tests have to be run within a specific time frame. I can tell you right now that if I'm going in and out of a critical state and I have to have my blood drawn twice, I'm going to wake up from whatever critical coma I'm in the second you sick me a second time to chew you out because I'm a tough stick. Let's say that I'm in the emergency room and my tests have been run and the provider responsible for my care is waiting on my lab results. And those results are trying to cross to an existing record, but the sex doesn't match. That's when the laboratory informaticists are going to be called to fix it on the lab's end. So I really need to stress that we shouldn't only rely on biological sex, but a combination of different patient information to ensure that patients receive the proper care that they need. Even if we change our sex in our record or we decide not to change our sex in our patient record, a mismatch can make it difficult to find the correct information for a patient. It can result in duplicate records or no record. Healthcare providers can waste precious minutes trying to search for a correct record. So we need to incorporate more gender-inclusive features that providers can rely on when treating patients, because certain time-sensitive situations require immediate care, and those lab results can't always wait. I can't be kept waiting in a critical state, and there are other patients who also need care who may be critical, and their care may also be time-sensitive. Patient demographic mismatches are not exclusive to queer patients, and they aren't an isolated issue. They don't always occur in an emergency room. They can occur anywhere where an electronic system is used, which these days is just about everywhere. Though I've heard recently, kind of to my dismay, that there are still some rehabilitation centers that rely on paper records, but we're not going to get me started on that right now. While the issue of a mismatch isn't unique to trans care, the frequency that it can occur for trans patients is higher, especially as more trans patients seek to transition and update their information. And healthcare providers need to be ready to treat trans patients and have gender-inclusive features throughout the health information system to identify these patients and ensure that they receive proper, often life-saving care in a timely fashion. They shouldn't have to wait for their care. And we shouldn't have to choose. Transgender patients shouldn't have to choose. We shouldn't have to choose between receiving proper care and running the risk of being misgendered or disrespected by our providers, or not receiving care at all. Providers should rely on more than just sex assigned at birth and gender to determine appropriate care for any patient. That isn't to say that we as trans patients don't have a responsibility to keep our providers up to date and informed. It's important that our providers know our sex assigned at birth, because our care is going to change depending on that variable. And even with the full sex change and complete transition, some aspects of our care, like certain lab values and appropriate medication dosage, is always going to depend on our birth sex in some form or the other. So there are two roles at play here, right? There's the role of the provider and the fact that they need to rely on more than just sex and gender. They need to rely on a patient's comprehensive medical history and not just a few factors when determining care. But there's also the role of the trans patient for us to be honest with our provider, and we should be able to be honest with our providers and still receive that respect and care we deserve as patients, regardless of our status as trans people. So what can we do, right? I've already talked about how providers need to rely on more than just sex and gender, but what more can be done in terms of gender inclusive features to enhance appropriate care? I am a big advocate for anatomical inventories or organ inventories for patients. This is a feature that Epic has implemented, and I'm hoping more companies adopt. An organ inventory is an ideal solution, in my opinion. They can include organs a patient currently has, organs present at birth or expected at birth to develop, organs surgically enhanced or constructed, and organs developed with the use of hormone replacement therapy. An organ inventory can also include a list of surgeries that a patient has had performed to construct an organ, and it can include surgeries that intersex patients have undergone as well. Inventory data for an organ inventory can even link to corresponding ICD-10 codes to assist with billing purposes. I would consider organ inventories to be a crucial feature for all patients. A trans man who has had their sex listed as male, but who has a uterus in his organ inventory, can be appropriately recommended for a pap smear, and a trans woman who has a prostate in her organ inventory can be recommended for a prostate exam to check for cancer, even if her sex is listed as female. Not every cis person is going to have the same organs all the time either. Some people have their appendix removed, they might not have that. Some people have their tonsils removed, so they might not have that. Some women get hysterectomies, so they might not have a uterus. Having an organ inventory to keep track of what organs a patient has can also rule out redundant screening. For example, a woman who has had a complete hysterectomy no longer needs to be recommended for a pap smear and would be less likely to be denied care when seeking certain services that providers would be hesitant to offer if there was a risk that she was or could become pregnant. So this feature would really benefit all patients. We need to push for gender inclusive features every step of the way in every health information system, from the EHR to the laboratory and to our patient identification and phlebotomy devices. When I worked in laboratory informatics, I assisted in gender inclusive features being incorporated in our list system and advocated for gender identity being included for our phlebotomists as well, because of how crucial I consider these features to be for inclusive care. Incorporating these gender inclusive features in the medical laboratory would also lead to test results being flagged appropriately and result ranges that can be tailored to suit individuals undergoing HRT. If a patient who did undergo a sex change also changed their sex as listed in their chart, incorporating a gender identity field that lists a patient as trans could potentially prevent results from failing to cross to a patient's chart due to a sex mismatch if it's expected that trans patients may change their sex. I'm in favor of using more identifiers to pinpoint the correct patient rather than relying on just one. A lot of people are a fan of national patient identifiers or NPI numbers, but I don't think we should just be relying on one variable, because if an NPI is compromised, the patient's entire health record could be easily accessed in one location. Right now, the healthcare industry is leaning towards implementing biometric identification using palm vein technology, but I'm not entirely sold on that because the patient isn't always going to be able to provide biometric data. So we do have options, though not nearly enough, and we really can't give up trying to find solutions like incorporating more gender inclusive features for patients. We still have a long way to go to really make inclusive care accessible to everyone and to reduce the amount of harm caused by patient misidentification errors. That's really all I have for you today. I know it's a lot to think about and digest. I hope that you maybe learned something about trans healthcare from my talk and the need for gender inclusive features for all patients. I hope that you come away from my talk ready to ask your provider what their hospital is doing to incorporate gender inclusive care features. I hope you come away from my talk with a more in-depth understanding of where all your data might go in a hospital system and what can happen to it. And I hope that gets you as hackers thinking about how your healthcare data is transmitted and protected, and maybe what you can do to make sure it's secure and flowing. You might want to pay a visit to the biohacking village after this talk. I also have my references listed on the last slide for you to review and read through in your own time. If there's something I've mentioned that you can't find there, feel free to shoot me a message. And thank you for coming to my talk. I really appreciate you all being here. I took a look at healthcare from a different perspective than last year's talk, but I hope that you value and appreciate the information that you gained all the same. So I'm going to do my best to answer any questions that you might have. What questions do you have for me, if any?
This is Giglio. I work in the healthcare space. I don't have a question per se, but I just want to say thank you very much for raising this topic and having such a great presentation.
Thanks, Giglio. Really? No questions? Not a single one?
Yeah, don't be shy. Bring up your questions.
I'll ask one. What's your talk next year? And we're reserving you a space.
I'll have to come up with one, but thank you. I'd love to come back and talk again.
Awesome.